Good evening, everyone, and welcome to our latest primary care webinar on COVID-19 response and management in the ACT. We're really happy to be with you again this evening. We've got a panel of really expert speakers to talk about the public health response and where we are with regards to the epidemiology of COVID-19 here in Australia and the ACT. And then the focus really on this evening is on more of the management aspects, how we're tracking in terms of some of our planning for the acute hospital care setting, and the development and use of the National COVID-19 Clinical Evidence Task Force guidelines in primary care. Before we get started, I'd like to acknowledge the traditional custodians on the land on which we are meeting on this evening, the Ngunnawal people. I'd like to pay my respects to their continuing culture and their contribution they make to the life of this city and this region. I'd also like to acknowledge and welcome any Aboriginal and Torres Strait Islander people that are linking into the webinar this evening. I'm going to introduce the speakers one at a time. So we're going to start with Dr. Naomi Clarke. She's a public health registrar here at ACT Health, and she is going to provide a public health update first. Thanks, Naomi.
Thanks a lot, Vanessa. So as Vanessa said, my name's Naomi Clarke. I'm one of the public health registrars working in the COVID-19 response team here at the Health Protection Service. And tonight I'm just going to give a public health update on the COVID-19 situation in the ACT and talk a little bit about some updated guidance in terms of specimen collection and also in terms of the use of personal protective equipment. So I think most people are probably aware through regular media reports that Australia has really had a lot of great success in suppressing the transmission of COVID-19 recently. There have been really quite low numbers of new cases daily since around mid-April. There are still small pockets of community transmission, particularly in Melbourne and Sydney. And as well, we're detecting cases among international travellers returning from overseas who are in mandatory hotel-based quarantine. In terms of the epidemiology here in the ACT, we have 107 total confirmed cases, the last of which was confirmed now 22 days ago. And we've got no active cases with 104 recoveries and sadly with 3 deaths here in the ACT. We've now had over 16,000 negative tests in the ACT. And along with all the other jurisdictions across Australia, the ACT government is working towards easing all the restrictions that were put in place that were the part of the reason for such successful suppression of transmission. And just for interest, I'm going to show this infographic that was released on the ACT government COVID-19 website today that shows the pathway, I guess, out of the restrictions. So as of today, we are at step 2.1 of that. Well, step 2.1 of those restrictions was announced, which will take effect this coming Saturday morning. And that relates predominantly to the sizes of gatherings. I'll just revise the current testing criteria in the ACT, although it's relatively straightforward now in that, along with other jurisdictions in Australia and following the national guidelines, we're recommending testing anyone who has the relevant symptoms. But we do actually still have a suspect case definition. And the purpose of this definition is just really to highlight those individuals who have a higher pre-test probability of being diagnosed with COVID-19. So for this suspect case definition, people need to meet both the clinical and epidemiological criteria. The clinical criteria are a fever of greater than 37.5 degrees Celsius or a history of fever or symptoms of an acute respiratory infection such as cough, shortness of breath or sore throat. The fever threshold was lowered from 38 to 37.5 degrees this week, and that was in response to the growing evidence base and including here in Australia that people can present with very mild symptoms, including low-grade fever. In terms of the epidemiological criteria for the suspect case definition, this includes close contact with a confirmed COVID-19 case, recent international interstate travel in the 14 days prior to illness onset, travel on a cruise ship, which hopefully is no longer happening, staff who work in healthcare, aged care or residential care who have direct patient contact, and also hospitalised patients where no other source of their illness is evident. However, in addition to this suspect case definition, as I'm sure most people know, we are also now doing an enhanced community testing program, which means that anyone with those relevant symptoms, so fever, history of fever, or symptoms of acute respiratory infection are encouraged to get tested for COVID-19. And we're seeing a really good uptake of that with a significant increase in testing numbers since that enhanced community testing program was announced some weeks ago. In addition, more recently, a number of additional symptoms have been added to the testing program. These are less common symptoms of COVID-19, but still have been reported, and they include the loss of the sense of smell or taste, runny nose, myalgia or arthralgia, diarrhea, nausea or vomiting, and loss of appetite. And for these symptoms, we're really recommending that it's a clinician-based assessment, and if no alternate obvious cause is identified for a sudden onset of these symptoms, that testing for COVID-19 could be undertaken. And at this stage, we're still recommending that in general, people without symptoms should not be tested. Potentially in some high-risk outbreak settings, asymptomatic testing may be carried out, but as a general rule of practice, we're not recommending that asymptomatic people be tested for COVID-19. So you may also be aware that recently the specimen collection guidance was updated, and this was done by the Public Health Laboratory Network, and they now recommend a combined throat and bilateral deep nasal swab in order to optimize the chances of virus detection. So previously it was a combined throat and nasopharyngeal swab. And it's important to note that this can still be undertaken if the clinician feels it's more appropriate, and particularly if testing is also being done for Mycoplasma pneumoniae or Bordetella pertussis, a nasopharyngeal swab remains the swab of choice. But if it's just a COVID-19 test, it can be a throat and bilateral deep nasal swab. I'm sure I don't need to tell GPs how to do these swabs, but the information is there on the screen. And the important thing with the bilateral deep nasal swab is that, according to our Public Health Laboratory Network colleagues, that the swab is rotated several times after it being inserted and done in both nostrils. And we are still recommending that the same swab is used for both the throat and the bilateral deep nasal swab in order to preserve the numbers of swabs in Australia. And to finish, I want to talk, I've got a couple of slides on personal protective equipment, and I guess I want to acknowledge that it is really difficult at this stage in the epidemic in Australia to determine when a PPE should be used and when it shouldn't. And this is only going to get more difficult as we move into winter and see increased numbers of respiratory infections. So I appreciate that this is a dilemma that GPs are probably facing on a daily basis. I'll go through the current guidance from the infection control expert group, and we're happy to also take questions on this and discuss further at the end of the presentations. So we're still recommending that any patients who phone for an appointment or present for an appointment are asked about clinical and epidemiological factors related to COVID-19, so fever or acute respiratory symptoms, whether they've travelled, whether they've had recent contact with a suspect or confirmed case. And if no sort of suspicious factors for COVID-19 are identified, so no clinical features and no risk factors, then really we're just advising that standard precautions should be used, including the 5 moments of hand hygiene. And the decision to whether to use PPE should be based on a general risk assessment, depending on the presenting complaint, as GPs would do generally. And that should be done according to the Australian guidelines for the prevention and control of infection in healthcare. There's not evidence to suggest that we should be routinely using masks for all consultations with the low levels of community transmission that we've got here in Australia. And we're recommending that wherever possible, physical distancing should be observed. Obviously, this can't happen if you're doing physical examinations, but wherever possible, the 1.5 metres of physical distancing is advised. If there are any suspicious features for COVID-19, so this includes people who are in quarantine, who meet the suspect case definition, who may have been tested for COVID-19 or awaiting their result, who are a confirmed case, or who are presenting with acute respiratory symptoms, the advice is still provide patients with a surgical mask and put them in a single room or in an area that's well separated from other patients of staff. And then for the clinical consultations with these patients, to use contact and droplet precautions, which is a disposable gown, gloves, eye protection, and a surgical mask. This PPE should be changed between each patient, and testing for these patients should be arranged if necessary, if they haven't already had a test or been a confirmed case. I'll just reiterate here that if patients have severe symptoms suggestive of pneumonia, that specimen collection shouldn't be carried out by GPs in the community. These patients need specimen collection under airborne precautions in a hospital setting, so they should be referred to a hospital emergency department. So that previous advice in terms of contact and droplet precautions also includes specimen collection if that's being done along with a clinical consultation. However, if specimen collection is the only procedure being done, so the patient's not having a consultation or a physical examination, and this may be the case if a patient has called up in advance and said, I want to come in and be tested for COVID-19, and they're being tested, for example, in their car, then you still need to wear gloves, eye protection, and a surgical mask, but a gown is not needed in all circumstances. And while we're advising to change your gloves after every patient and perform hand hygiene, the goggles do not need to be changed during consecutive patient specimen collection in the same location, and surgical masks also don't need to be changed unless they become wet or otherwise soiled for a period of up to 4 hours. This is if a person is doing consecutive patient specimen collections in the same location, so not if they're doing consultations. Similarly, if a gown is chosen to be worn, it can be worn for consecutive specimen collections, but should be changed if it becomes soiled or wet. And it should also, all PPE should be always changed if you leave the area to do anything else. So that's all from me in terms of a public health update. I'm happy again to take questions and answer those at the end. And otherwise, I'll pass on to Vanessa to introduce our next speaker. Thank you.
Thanks, Naomi. So I'm handing over now to Professor Kirsty Douglas. She is the Director of the Academic Unit of General Practice at ACT Health, and she is a Professor of General Practice at the ANU Medical School. Currently, I understand she's the Acting Director of the ANU Medical School, while Professor Imogen Mitchell is doing some work here at Canberra Health Services, and she'll be one of our speakers this evening too. So Kirsty Douglas this evening is going to be talking about the National COVID-19 Clinical Evidence Task Force Guidelines. Thanks, Kirsty.
Great. Thank you for the introduction. I'm not even acting as the Dean of the Medical School. I'm just supporting Zhizhoka Keshkesh, who is doing that. And the most important qualification I have for doing this talk today is that I am still a practicing Canberra GP clinician. So I was just asked to talk a little bit about the national COVID guidelines. I was lucky enough to be asked to join one of the National COVID Clinical Evidence Task Force committees. And so I've become involved with this process and was just asked today to talk a little bit about it and to make sure that our local GPs are aware of this useful resource and so they can access it. So the National COVID Clinical Evidence Task Force is a group that has been quickly developed and funded to try and provide a sort of one-stop shop for the best evidence supporting best care during the COVID pandemic. And this is just a snapshot from the website. So importantly, it's a living evidence guideline, which is a new trendy thing in clinical guidelines. And living evidence is unlike sort of old clinical practice guidelines where you, for instance, get the Heart Foundation to develop a congestive cardiac failure guideline, and it takes 3 years to do it. And by the time it's actually published and on the website, they're already working on the next one. And it's, by the time the next one gets updated, the first one's 3 years out of date. So living guidelines is a new process which is designed to allow continual active evidence surveillance and monitoring. And it's a process by which new evidence can rapidly be incorporated into existing guidelines. The process relies on being able to have good digital spaces to communicate frequently with stakeholders about the current status of the review or the guideline, and underpinning the process of living evidence is that there is active engagement with large and diverse groups of stakeholders. The recommendations in these guidelines is published on easily accessible systems, and I'll show you the website link in a minute, and that it's produced in a way that can be easily integrated into electronic medical records or commonly used decision support tools. So it's really just a new process to try and make sure that best evidence is collated quickly and distributed effectively with oversight by relevant stakeholders. The National COVID Task Force is convened by the Australian Living Evidence Consortium. It's actually based at Cochrane. You've probably all heard of the Cochrane Collaborative, the Cochrane Australia's centre, which is at Monash University. It's funded by the Australian government, so no pharmaceutical companies involved, so all independent funding. And it's got a national steering committee led by Julian Elliott. The funding provides funding for a core staff or evidence team of about 15 methodologists and evidence-based medicine practitioners who literally spend their days trolling through data. And then they have developed 5 panels and 1 expert advisory group of basically volunteer stakeholders. And the one that I'm going to refer to mainly is the primary and chronic care panel. And that's a panel that I am part of, and Jason Agostino, who works for Nacho and is another local GP, is also part of that panel. So they're really trying to develop the panels where those group of people then look at the evidence that's being collected and make sure that it is relevant, and the recommendations are made in a manner that will be useful to the stakeholders. So basically, we're trying to develop a growing set of evidence-based recommendations that guide care for people with COVID-19 and that are kept up to date as the new research becomes available. And obviously, you know, with this pandemic, the keeping up to date with new research is critical and rapidly evolving. I think there are currently 2,000 randomized controlled trials around the world being conducted around hydroxychloroquine. So, you know, just trying to keep track of all of those is a task in itself. And of course, the Australian guideline group is in regular contact with the equivalent in the UK and many other OECD nations. At the moment, our primary and chronic disease task force is having weekly meetings. So the core group do the analysis of new trials that have been published or case series that are being published, and they then synthesize that, update recommendations, and then the clinical experts meet weekly. So every Thursday night we meet for an hour to review the evidence summaries and look at whether we need to update the existing recommendations. And also importantly, we have an opportunity to feed back in terms of what are the issues that are arising in our clinical settings that we would like better quality evidence for. And then by the Friday, the base team has then published and updated that weekly's evidence summaries. So if you're looking for what is the best evidence at the moment around COVID treatment, then this is a really good place to start. I would just highlight that this group is focused on the assessment of suspected and the treatment of established COVID, all right? So the questions about who's at risk, the recommendations around PPE use and infection control are generally covered by other expert groups or other committees. And Naomi has already talked about the Australian Health Protection Principle Committee. That's the sort of overarching committee that works with states and territories to develop and adopt national health protection policies. And they have 2 subcommittees, Communicable Disease Network Australia, or CDNA, and the Infection Control Expert Group. So issues around PPE will largely be looked at and evidence collected by the Infection Control Expert Group, and the Communicable Disease Network has really got that population health protection angle. So this National COVID-19 Clinical Evidence Task Force is really looking more about the treatment. So this is the critical web link. If you actually Google Australian COVID evidence, you'll find it very quickly. But if you're looking for the actual web link, it's here. And then the areas that I think you will be most interested in is there is a series of clinical practice guidelines. And this is just a screenshot from it. Again, you can see I've gone to the clinical flowchart, and there's one around the assessment for suspected COVID-19. It takes, you know, the talk that we've just had from our own health department this is reflected in that. So it takes it through that. Then the second one that I think most people will find helpful is there is a clinical practice guideline on the management of mild COVID. So over here, it's got a definition of disease severity, and there's another section which actually takes you through how is it COVID disease severity being formally distinguished in Australia. And then it has the management in the community. And again, I don't think any established GP will find this is particularly rocket science, but this clinical practice guideline is based on the best available evidence that we have at the moment. This is another section which again is easy to find. It is a consensus recommendation because there's not strong evidence for this, but this is the consensus of the expert teams is this is how we should be characterising mild, moderate, severe disease in Australia. And again, in mild illness is really what we're going to be dealing with in general practice. And that is usually no symptoms or mild upper respiratory tract symptoms with myalgia or asthenia, but stable and in no distress. And then importantly, also on the website, there is a feedback option where you can talk about what are the questions you would like evidence about at the moment. Again, depending on the focus of the question, it will either go to this group or this group may then feed it back to the AHPPC. For instance, in last week's discussion amongst the stakeholders, there was quite a lot of us saying that the issue that we are struggling with at the most is as Australia is moving to get back to less shutdown, one of the critical points that we are being asked about for our patients is who really is at increased risk and who do we need to probably protect from going back to the workforce or school, but versus who can we say, you know, go back to work with confidence. And certainly there was broad categories identified by the AHPPC initially, and you know that was around age, hypertension, chronic diseases, immunosuppression. As the pandemic has evolved internationally, we can probably get cleverer about realising who is at significantly increased risk. And we are waiting with bated breath because we believe the AHPPC is going to produce some updated guidelines about identifying those at risk. Some of the questions that have been identified in recent weeks and which there is evidence statements around on the website are issues like, should we continue patients on ACE inhibitors, yes or no? And the simple answer to that one is yes. Another one is, what do we do around patients with mild asthma who have COVID? Should we be stopping their steroids? Should we be increasing their steroids? And at the moment, the evidence around that is we should continue their steroids as they, due to their asthma, as we would just for their asthma without their COVID. But that's really to give you a little bit of an oversight of what the process is about how the guidelines are developed and to show you where to find them. I think they are at the moment presented in a reasonably engaging form, and certainly it is possible to download, as I know some of my colleagues have, download the guideline. The one thing I would say is they are being updated regularly. So don't download a guideline, cover it in plastic and stick it on your door and forget about it for the next 6 months, because it may well have changed if your first case of COVID that you're actually dealing with occurs in 3 months' time in phase 2. Okay, that's it from me.
Thanks so much, Kirsty, and thank you for clarifying your role at ANU, and apologies for that. That was really fascinating. I actually learned quite a lot. Thank you. We are going to hear now from Cathie O'Neill. She's the Executive Director of Cancer and Ambulatory Support at Canberra Health Services, and she's going to talk to us a little bit about outpatient referrals and appointments. Thanks.
Thanks, Vanessa. Good evening, everybody. I've been asked tonight just to give you a very brief update around what's happening with specialist medical outpatient services at Canberra Health Services, particularly related to the easing of the COVID restrictions. So, as you would be aware, we reduced non-admitted services down to non-essential, non-urgent services in March. We quickly transitioned many services to using telephone in the first instance, and we've since gone live with the Health Direct telehealth platform, and we're starting to see more and more uptake of that platform across our outpatient services. The advice to services as of last week is to start to increase services back to normal volumes, but trying to also maintain the requirements for physical distancing within the clinics themselves, and also still trying to maintain a reduction in the number of people accessing health services. So many of the services are looking at restructuring their clinics so that they can use a mix of physical face-to-face, telephone and video appointments, so that they can actually spread out the people presenting physically. And we'll gradually ramp back up to full capacity over the next fortnight. So in terms of referrals in, we encourage you to send in referrals as per normal, and we will be triaging those. And we're just starting to do a bit of planning to assess the full extent of any backlog that may have accumulated in the last couple of weeks, and some strategies to address that backlog. And when we've got more information about that, we'll be sure to let you know. I guess it's just important, if any of you think your patients may have got lost in the last couple of weeks in terms of outpatient services, please make sure you contact either our central health intake line or GPLU, so that we can just make sure that people haven't been disadvantaged during this period. And I'll leave it there, and happy to take questions at the end of the presentation. Thank you.
Our final presenter this evening is Professor Imogen Mitchell. She is the Director of the ANU Medical School, but is currently working at Canberra Health Services as the Clinical Director of the Canberra Health Services COVID-19 response. And she's going to talk to us a little bit tonight about acute care sector planning. Thanks.
So I have the great privilege of being the clinical director for the ACT COVID-19 response, and now wondering what I'm doing, because thankfully the public health doctors have done so well that we thankfully don't have that many patients in the hospital. But that has given us some time to plan, and I'm going to walk you through what we've done so far. So I'll just talk about, if I can get the slides to move. Here we go. So what I'm going to do is talk about the governance of the emergency response. I'm sure you've heard quite a bit of that already. The role of this Clinical Health Emergency Coordination Centre, what plans that we've made, and also what we're now going to be doing in terms of operations to respond to this pandemic. So the governance of the emergency response originally just resides with the Chief Health Officer. So the Chief Health Officer is the Health Controller, and under the Public Health Act, coordinates, directs and leads the territory's response. It became quite evident that probably the skill sets of various people in the territory was such that maybe what we should be doing is looking at separating off public health and the primary healthcare response from the acute care services. So at that point, it was decided that we should have a deputy health controller, and that was going to be the CEO of Canberra Health Services. This is what happened also, I think, in South Australia. I think they actually had 3 deputy health controllers coordinating their acute care services response. And so through the deputy health controller, who now chairs this new committee, which had to be established, the new committee is the Clinical Health Emergency Coordination Centre. And that's the body that's really done the work in terms of planning for the acute care services. So we have the Clinical Health Emergency Coordination Centre, which when really stood up and operating, it would then initiate the HEOCs at both of the hospitals to actually do the operationalisation of the emergency response in the acute care sector. And that Calvary would obviously look after the Calvary-based hospitals, including John James and Calvary Private, and that the Canberra Health Services would also look after National Capital as well as UCH and the Canberra Hospital as well. So that's the governance of the clinical acute care services response. And then you'll see that just in the middle there, you've got the clinical, well, what we're now calling the CHEC, not the check, the CHEC, because we feel that the FEC is rather probably problematic, so we call that the PHEC and the CHEC. The CHEC is looking at planning in terms of response to increasing in demand, and also looking what logistics we need to manage that response, and obviously the clinical operations, which happens more at the health delivery end, the hospitals. And I'm there just to really oversee the clinical response to the pandemic. So we provide clinical advice, clinical direction, and provision of health services. I think we need to be clear, it's acute care health services to the ACT. And we've agreed, certainly with New South Wales Health, that we would manage the surge in terms of the critically ill for the New South Wales region, just as we do now. So nothing would change in terms of referral patterns for us. The thing that we focus on in terms of the CHEC is that we need to identify the capacity, the current capacity of the hospital-based services. We need to identify workforce and what workforce, and particularly the logistics, which obviously includes the personal protective equipment across the territory. And we also need to look at actually managing this clinical services for the ACT and the region. And we clearly have to work very closely with the PHEC. The reason I feel that we need to work very closely with the PHEC, not least so that our healthcare system is operating as one, but particularly if we see and start to see an increase in demand of the acute care services, our recommendation would be going back to PHEC, saying that we need to start looking at the social distancing and locking down the doors again, because our capacity will be exceeded. I think that's an important connection for us. So the objectives, as you might reckon from what I've just said, is that we need to obviously enable the healthcare providers. We need to importantly protect our staff, and that's obviously having enough PPE. It's also having the people trained in PPE. And we also need to, as I mentioned, provide advice to the ACT government and coordinate requests that might come from various places, and obviously educate providers as to how we might manage this pandemic. So there are obviously, over the last few weeks, things that we have completed. There are still things that are outstanding. Things that we've managed to complete is having some, if I can get the slide to move, have a model of care principles. So these principles will be guiding us all the way through the pandemic. Our first principle is that we're going to protect the staff, and I think this would go across the territory. That what we would do is always, I guess, if you like, externally triage patients such that we deem them all high risk COVID. That is, we either suspect that they're COVID positive or that they are confirmed until proven otherwise. This is really to save, I guess, the the transmission to other people and patients, but it's also to try and save some PPE if we are starting to cohort COVID positive patients. that we would look at the public hospitals in particular remaining as a mixed environment, so COVID and non-COVID or low-risk COVID. And we would always need to maintain Canberra Hospital as having the tertiary services, so that if we had any time-critical patients, that we would bring them to the Canberra Hospital. So, you know, things like acute subdurals or trauma or ruptured AAAs. And as I mentioned previously, our referral patterns would remain exactly the same. So we would not be treating New South Wales patients in the region any differently to what we do now. One of the keys I wanted to establish that if anything that we do from the CHEC point of view, is that every plan that goes into place must have these principles in terms of protecting the staff and our infection prevention and control principles. So that we expect, as we should anyway, but this is certainly ramped up our infection prevention and control, so hand hygiene, that we must align to the national guidelines on PPE usage, and that means that we have to track it as well. And we've certainly seen an increased use in the P2s, the N95s, probably inappropriately, so we need to make sure that we actually capture the data so that we can then inform the staff that they don't actually need to use the N95s. Certainly in the acute care sector, we will start, if they haven't started already, certainly at Calvary and National Capital, the syndromic surveillance of staff, and also the syndromic surveillance of visitors that come into the facilities. At the moment, although there is pressure to change this, we would like to minimise the number of visitors. We realise that's very difficult both for families and the staff. But given that we're opening up the floodgates in terms of social distancing, probably for me now is not the time to start increasing the number of contacts coming into the hospital, because the last thing we want to be is the hub for COVID. We also have been quite strict about the social and physical distancing, and also the fact that we wanted to minimise the numbers of staff going home in uniform such that they were not targeted. So there are steps obviously in the making, and those are still the plans. The plans, some of them are well formed, some of them still need some attention. So obviously the walk-in centres have had a lot of planning in terms of coping with the capacity that we had early on, and indeed of ramping up pathology testing as well. The three big plans that we've been working on because of the reflection of the disease entity itself, knowing that 5% of those with COVID get admitted into the intensive care unit. We've been working on intensive care plans, the emergency department and inpatient plans of working to what we have now, I guess, looked at 4 stages of increasing our capacity. So we describe it as responding to a demand which is current, so that we're looking at spaces like intensive care remaining within the walls, but only what we're funded to at the moment, because we would have 31 physical bed spaces, but only be funding enough staff to look after 24 patients. Then we go to flex. That would mean that we would increase the demand such within the walls of the intensive care unit, so up to the 30 odd beds. And then we would go to surge capacity. And that means that we would now have to look for geographical spaces outside of the intensive care unit, and likewise with ED. In the surge phase, in fact, we start using the Aspen Surge COVID Centre. And then super surge means that we're finding even further capacity in ward areas for intensive care patients, and ED would also start expanding out into places such as medical imaging. So places where we'd not normally have our emergency patients. And inpatients, again, as we start to use at ward areas, they would have to further minimise elective surgery and any other admissions that we can safely avoid. And I think when we're looking at the emergency presentations, I think even in super surge, we'd be looking at 1,200 presentations a day. We would at least anticipate 600 of those presentations would need another mechanism for being reviewed in terms of not being seen at the hospital. So whether that's building out the walk-in centres, looking at discharging patients into hospital, in the hotel, and other odd ways of caring for patients. So the plans are looking at physical space. The plans look at workforce, because obviously as you increase the capacity and the demand, you need to work differently. And obviously we need to look at logistics, which includes medications. Probably, if anything, medications are going to be our rate limiting factor in looking after intensive care patients. We don't have enough paralysis agents. We obviously need to increase the capacity in terms of IT, ventilators, consumables, and importantly, PPE. So these plans all address these various items. And then there are other plans are looking separately because they're not really surge plans, although obviously at the moment we're looking at surge in mental health because of all the impacts that COVID has had indirectly. But looking at plans for surgery, their model of care would change drastically because as they reduce elective surgery in the public places, they would increase capacity in the private hospitals. And we would look at doing women's, youth and children's a little bit differently. And clearly we need a very clear end of life care plan. And on that note, I shall finish.
Thanks, Imogen. That was really great. And as Imogen said, the PHEC and the CHEC work very closely together. We've been particularly engaged with Cathie's teams in the walk-in centres in the last couple of weeks in referral of some of our hotel quarantine guests on the airplane load from India. 208 guests have been in mandatory hotel quarantine the past 14 days. And Canberra Health Services has provided a very high level of care to some of those individuals, including widespread testing today. So that's been great. And obviously where we intersect in the before hospital planning, primary care plays a really big role there, and public health and primary care have been working very closely on designing a primary health care preparedness and response planning framework as well. And we hope to talk to you about that in the next couple of weeks, or at least in the coming month. So we do have some questions. And I am going to, okay, so there's a few questions for public health. So I might take a couple of these and give some to Naomi as well. So the first one is children are presenting with mild urgy symptoms with return to school and childcare. Yes, I can attest to that. I have a 5-year-old. We can encourage families to get children tested, but are we really expected to persuade and test all children when there are no epidemiological risks? And I understand this dilemma with a 5-year-old child. We know that the testing is not particularly comfortable, and all of the evidence would suggest that children by and large have mild disease and are not strong transmitters of COVID-19. So while we would really encourage, as we've said all along, to get people with symptoms that meet the testing criteria tested, you know, I think it's really up to the parent and guardian of that child. Certainly what I would say is that those children cannot attend childcare or school. If they're not going to get tested for COVID-19, then they definitely need to be at home and be isolated until their symptoms are fully resolved. And if they're not going to get tested, but the parent or guardian then gets sick, they definitely need to get tested. So, you know, I don't think we can be black and white here. I understand that dilemma. I would encourage you to encourage them to consider testing as the government testing facilities, and certainly potentially you yourselves might be comfortable in testing young children. But if that is not what the parent or guardian wants to do, then certainly keep them at home isolated and test the adults if they become symptomatic. Kirsty, do you want to add anything to that?
No, I think that's right. You do have to take an individual approach. I mean, I think many parents, once you start talking about keeping the child isolated at home, suddenly think that a nasal swab isn't so bad after all. But, you know, I think we have, as always, guidelines are guidelines, and they should be telling you what the evidence says, but the best evidence-based practice is a combination of the evidence with your specialised knowledge and history of the family and knowing how they'll adapt to things. So I think what Vanessa's outlined is probably appropriate.
Thanks, Kirsty. The next one is around recommendations for vulnerable people returning to work. And as Kirsty said, we are awaiting a revised AHPPC statement on who exactly is vulnerable to more severe illness from COVID-19. But the question relates to the fact that many people are seeing GPs and seeking certificates to support their continued working from home. So the ACT government advice is where it suits you and your employer, then we would recommend working from home as much as possible to reduce the risk of transmission and just to continue the physical distancing that we've done so far, even as other restrictions start to ease. We do say also for those who are vulnerable that they should discuss their particular situation with their GP. Obviously, someone who has really uncontrolled diabetes and other comorbidities and is over 70 is much more vulnerable than someone who is 65 and is well controlled on diet and exercise alone. So I think although these categories capture population groups, they don't talk to an individual's risk and vulnerability, and that assessment needs to be made. And then I think the discussion, if someone thinks that they need to work from home because of their condition, then the discussion with the GP needs to be around, well, what kind of risk mitigation measures might be able to be put in place in the workplace if your employer wants you to go back to work that might reduce that vulnerability. So if you're a frontline healthcare worker, for example, and you've got significant immunosuppression, could you talk to your patient about giving them a certificate to not work with in patient contact areas, but work offline in other areas? So I can imagine that there are people seeking the support of GPs to not go to work and to go to work. I think there would be people in both categories. And I think the role of GPs is to really make that individual assessment and to work through, well, if the employer feels that you can't do the job from home, are there any measures that you feel comfortable in supporting? If there are not, and you really feel that that's in the employee's best interests, then fully support you writing that certificate. So I hope that's answered that question. I can understand there would be some pressures on GPs from both sides at this point, but it's an individual risk assessment that we will be asking for. Are we expected to test patients with asthma, COPD who have a chronic cough and then have mild exacerbations? And I guess that really depends on the triggers for their exacerbations. I think if that's in the context of an upper respiratory tract infection and that therefore those symptoms meet those testing criteria, then I would suggest yes. But if they're young children and the exacerbation is due to increased physical exercise or cold weather or some other trigger, then it may not be appropriate. Kirsty, I'm not a clinician. I should really pass that to the clinician.
No, I think you're doing very well indeed, Vanessa.
Thank you.
That's exactly what I would have said.
Okay, they've come under the public health bag, but I think that was a clinical one. Kirsty, I'm going to ask you this one first, and then I can come at it from the public health angle, because I'm not exactly sure what the person is wanting here. So we'll try and both tackle it. Are there recommendations about managing patients in aged care facilities who have suspected or confirmed COVID-19?
The National Task Force is actually convening this week a special aged care expert group, of which I'm not part of, but to try and make sure that they run an eye over any of the recommendations that are coming out with a view to how that would roll out in aged care settings. So in terms of that task force, they have recognised that that's a particularly vulnerable group and a healthcare setting that has particular structure and impositions on it. In terms of the clinical setting than it really is around understanding the person's vulnerabilities, whether they have mild, moderate or severe disease, and you know, if you're in an aged care setting, what their end of life wishes are and if they've been documented. So certainly I, like a lot of my colleagues, I think have been spending specific time with our older patients, asking them if they have an advanced care plan and letting them know that that it's probably a good idea if they haven't to make sure they have one. And thankfully most aged care settings now require one before admission. But it's a good time to relook at that. But I think in terms of my understanding of that question is probably what, in terms of the health response committees in ACT Health, have you put in place to manage potential outbreaks? Because there's a range of different organisational arrangements. So for some aged care settings, there are multiple different GPs that go in to visit individual patients. But presumably if one patient is identified as COVID positive, then one of the first things you're going to want to do is reduce the number of people going in and out of that setting. So has there been a process set up for that? And if so, how is that going to be communicated with the broader GP group?
So certainly we're looking very closely at how we would prepare for an outbreak of COVID-19 in an aged care setting. And ostensibly for us, that equates to one case, particularly if it's in a resident who hasn't left that facility, because it's likely that there are probably already various multiple levels of transmission if we detect that. So we're looking at this very closely. We're looking at it in terms of not only the public health aspects, but the clinical aspects. So from the public health side of things, how we would effectively work with the facility to isolate confirmed and suspected cases and contacts, and how we might cohort those groups, how we might zone staff to specific areas so there's no cross mingling, and how we would rapidly set up a very widespread testing regime across that aged care community, because I think the experience from other jurisdictions is that by the time you detect a case, if it's not in a healthcare worker that's come from the outside, but it's in a resident that hasn't left, you've got multiple cases already there. Some of them may be asymptomatic, some of them may be pre-symptomatic. So we're working with ACT pathology, thinking through how we would ramp up that schedule of testing. In terms of the clinical side, I think there's another question here around how we would surge capacity for palliative care in aged care facilities in the event that there's an outbreak, and we would expect that there would be a significant number of people that wouldn't potentially want active management. So we've been talking to our Canberra Health Services and Calvary colleagues in the GRACE program and across territory-wide palliative care around how we would do that. And I think, Kirsty, I think you're right in identifying the fact that the complexity here is the multiple GPs that may look after various patients. We'd be wanting to work with the facility very closely with those GPs. We would never seek to restrict entry at all, and would be wanting to work very closely around those individual care plans, and probably still we have a bit of work to do to bed that down. But it's our planning is in a very active stage. So I agree. I think that's where the question was. In an outbreak scenario, how do we manage that when there's a lot of different stakeholder groups, including families, facilities, staff, general practitioners, and a whole host of players there. So we're working towards bedding that down. Naomi, I'm going to give you one. So can you explain the evidence for changes to the testing regime? So GPs are getting mixed messages around resource issues like swabs and PPE, but versus what the evidence tells us is best in terms of when and how to test.
Thanks, Vanessa. So I clarified with the person who asked this question that the question was specifically to do with the evidence for deep nasal swabs versus nasopharyngeal swabs that changed recently. And I mean, this was a recommendation that came out of the Public Health Laboratory Network after reviewing the evidence. And the decision was based on the evidence that when done appropriately and correctly, a bilateral deep nasal swab is likely to be equally effective at detecting virus as a nasopharyngeal swab. And certainly a deep nasal swab is preferable from a patient point of view in terms of comfort of the procedure. And an additional factor, which I think goes back to this question, is that it also relates to the fact that nasopharyngeal swabs can only really be done using a very fine flop swab, whereas deep nasal swabs can be done using a wide variety of swabs. And certainly there are lots of different swab types in circulation. And so the recommendation for a bilateral deep nasal swab means that that can basically apply to most swab types that clinicians and testing facilities would have available. But that said, it's really important to note that clinicians are still able to do a combined throat and nasopharyngeal swab if they prefer. The recommendation isn't that this is no longer permitted. That's still certainly fine, and it's still going to be very effective in detecting virus. But that should only be done if the appropriate swab type is available. Yeah, GPs can feel free to still do nasopharyngeal swabs if that's if they have those swabs and if that's what they feel is appropriate for that particular patient.
Okay, these are for Cathie. So Cathie, the Canberra Hospital outpatients using Health Direct video call widely. Are patients using it and comfortable with its use? And secondly, is community nursing back to functioning as BAU? Usual.
Thanks, Vanessa. I'll do the second one first. It's a little bit easier. So community nursing is ramping up back to normal levels. They are looking at changing some of their models of care, but that shouldn't impact on GP sending in referrals for community nursing. So I would recommend that you just send those in and they will be dealt with appropriately by the service. In terms, Anne-Marie's just put in another one. I can see on the screen a secondary question to that. Are they doing home visits? I'll have to take that one on notice. I'm not sure about that. In terms of the use of the video calls, the uptake is steadily increasing. And I think there's a couple of reasons for that. We converted to telephone very quickly, and I think many of our clinicians have been surprised at how effective telephone calls have been. And whilst we implemented the Health Direct platform relatively quickly for our service, we've still got a few teething problems in terms of integrating it to our other systems. And so we're working with our clinicians. One of the things that we've also started some conversations with Capital Health Network and in particular endocrinology and rheumatology is around doing some pilots for early transition back into primary health care using telehealth so that we can do some shared consultations with GPs. I know this has been tried in the past, but the old technology made it quite cumbersome, whereas we're hoping this new technology is something that we will be able to easily dial in GPs and other third parties so that we really can encourage that collaborative care and also that early handover back to primary health care. So watch this space for that. Can I stay here? Sure.
So Naomi thought you might be able to add to my comments on whether what the surge capacity is for palliative care and aged care facilities in the event of an outbreak.
Sure. So similarly to the planning stages that Imogen outlined, the territory-wide palliative care group, which includes representatives from aged care and primary health, have been working on a staged approach to that increased demand. So much of our work has been around how we would increase our consultative services to aged care for the provision of palliative care, because it's really up to the aged care providers to actually provide that on the ground service. So we've been, as I say, focusing our efforts on how we would quickly ramp up the provision of that higher level support. And we've been working very closely with the peace nurse practitioners, who used to be called the inspired nurse practitioners, if you're not used to the new term, so that we can really get in and support aged care if we needed to. We've also Kirsty, I think, mentioned around end-of-life plans. We've also been using our advanced care planning team at Canberra Health Services to provide additional support to aged care facilities to really make sure we've got maximum coverage of end-of-life and aged care plans in place.
Okay, so what is the evidence for self-collected swabs, especially if not directly observed by a clinician? So if you go to the most current cDNA song for COVID-19, in the lab, in the specimen collection section, it does say that the Public Health Laboratory Network has reviewed the evidence for self-collected swabs under the supervision of a healthcare professional and is satisfied that this has been shown to be equivalent to laboratory collected swabs by a practiced specimen collector. So that under appropriate medical supervision, it is permitted under the song to be able to utilise self-collection. At this stage, it's not recommended that that be done unsupervised. Certainly, the Public Health Laboratory Network are continuously looking at new testing regimes, acknowledging that nasopharyngeal swabs and deep nasal swabs are quite uncomfortable. I've heard from some people that it's akin to kind of having your brain stabbed, and it sounds pretty horrible. So we're looking at ways to make that less invasive so that we maintain that high uptake of testing. So I know researchers in Melbourne, in Victoria, have been looking at the validity of PCR detection in saliva samples, and while that's not ready to be rolled out broadly, we hope that in the future there may be opportunities there, and even for self-collection at home and sending in the post. So there is continuous research around better ways to collect these samples that are less invasive and require less effort from patients than showing up at a testing site. So the other question we have is whether the task force have recommendations for senior schools that have boarding schools, and if they get a COVID-19 case. So we've been working with the Education Directorate. I think I'm right in saying that the ACT has only one boarding school at a senior school, but ostensibly the same principles apply in an aged care facility as they do in other residential care settings, noting that obviously younger, healthy, otherwise healthy children are at much lower risk. That the public health unit would be leading that response. We would be doing the same detailed case investigation, widespread testing, trying to cohort cases and contacts. In that scenario, it may be much easier to decant those children either to hotels under adult supervision or back to their families. So there are I think it's much more straightforward in that kind of shared accommodation, but the general principles apply, and the Education Directorate has been looking at risk mitigation and preparation in that setting as well as across specialist schools that manage children with disability and special care needs. Please. Oh, Cathie.
Hi, I've just managed to get in touch with Linda Colhagen around community nursing. She advises that they never actually stopped. They did reduce some services where it was feasible to do so, but they have now resumed full services. Allied Health are also doing home visits, and ACAT are also doing some home visits, but only by exception. So hopefully that clears that one up. Back to you.
The last question I'm going to answer tonight is looking at the clock, and it's 20 to 8, and I think people who haven't had their dinner and glass of wine are hoping to get to that soon. I certainly am. Oh no, there's another question come through. What's the current thinking on test sensitivity? So I think here, I'll talk about the PCR test and assume that's what we're referring to. Look, I think that the general advice is that we think this to be a highly sensitive test. It's a PCR test that can detect very low levels of the viral genome. Although some people do put out sensitivity and specificity in the literature, there really is no gold standard by which to compare it to. So that's a little bit contested. I think we'll call it an evening, folks. Thanks very much for your participation as always. Thanks heaps to our speakers. It's been a really interesting evening from my perspective, and we expect to see you soon in the coming, we expect to speak to you soon in the coming weeks and months as the response evolves. Thanks very much.